All right, so this is actually one of my favorite topics. Not because it's so esoteric, but because I think there's actually a framework where we as radiologists can be quite accurate in this disease setting. So my disclosure, I already discussed these. We won't talk about them in detail. So if after this talk, you're better able to list the common cause of cystic lung disease, you can identify the presence of cystic lung disease and have a general diagnostic approach. And you discuss specific findings more suggestive of Birt-Hug-Dubé syndrome cystic lung disease as opposed to lymphocytic interstitial pneumonitis. I feel like I would have been successful. So if you Google diffuse cystic lung disease, you get probably at least 10, maybe even 15 different causes of acystic lung disease. And if we list some of the more common ones, they are shown here. So these first 6 ones, these are the ones that we commonly will discuss. But really the first 4 are the cystic lung diseases that most pulmonologists and most chest radiologists think about when they're first approached with a diffuse cystic lung disease. This will cover well over 95% of the cystic lung diseases. And then this is sort of a high yield course, so we're gonna cover those in detail. Before we talk about the specific cystic lung diseases, very seldom will these patients come in with a stamp of a diagnosis, right? Some patients come in with like known history of cystic fibrosis, or they'll come in with known emphysema. Those are pretty easy diagnoses to make because they already have the diagnosis in hand. A lot of these patients with cystic lung disease, they come in with just non-specific symptoms, or maybe you got a CT for another reason, maybe you got a lung cancer screen or CT, and they clearly have some sort of cystic lung disease phenotype. How do you approach this? And so understanding that emphysema is much more common than cystic lung disease and sometimes will sort of overlap in the imaging phenotype with cystic lung disease, the first thing to do is to exclude central lobular emphysema and paraseptal emphysema. And I think in most situations you can do that. And then you also have to ask yourself, are there enough cysts? So if a patient walks into your CT scanner, outpatient, and they have no known history, and they have a couple of pneumatoceles, a couple little cysts in their lungs, is that diffuse cystic lung disease? Probably not. So the question is, how many cysts are enough? Because you can get post-infectious or post-inflammatory or post-traumatic pneumatoceles for a bunch of reasons, right? The lungs are only so smart. They can only heal in a certain number of ways. And so it's not uncommon to get these scattered thin-walled lung cysts, pneumatoceles, especially in older patients. And so what was taught to me was 7 cysts or more, you should seriously start thinking about diffuse cystic lung disease. What's the literature on this? There's very little literature on this. The 7 cysts, that was based on very poor data and mostly expert opinion. But I've heard other chest radiologists use that same number, 7 to 10 cysts. So if you have someone with 7 to 10 cysts, more than 7 to 10 cysts, you should be thinking about diffuse cystic lung disease. So once you're sure you're dealing with cystic lung disease and the patient doesn't have emphysema, what are our differential diagnosis? Again, it's those 4 things. So the way that I approach it is I first want to exclude LCH, right? So LCH and LAM are 2 of the most common cystic lung diseases, but really the approach is to ask yourself first and foremost, is this LCH, Langerhans cell histiocytosis? Why is that? It's because it looks so different from the other cystic lung diseases. And I'll show you a bunch of examples in just a bit. It's very, very different. And I would say in terms of cystic lung disease, usually it's not a diagnostic conundrum when you have a case of classic, and not even classic, sometimes sort of like atypical pulmonary Langerhans cell histiocytosis. It just looks different from the other cases. Then you consider LAM, lymphangioliomyomatosis, lymphocytic interstitial pneumonitis, and Birt-Hug-Dubé syndrome, probably in that order. So let's show examples of emphysema. First, this is a classic example of paraseptal emphysema. You guys see this all the time in practice. I don't need to explain to you what paraseptal emphysema looks like, but just don't confuse this with the cystic lung disease. Sometimes these central lobular emphysema cases, they can kind of look like cystic lung disease, especially if they got a little bit of fibrosis or scarring on top of it. We also know that smoking can actually cause a little bit of fibrotic changes in the lungs. And sometimes when you get a combination of emphysema superimposed on this reticulation, a little bit of scarring, it can look like cysts. But most of the time, these areas of emphysema, they're not going to have walls. They're going to have the central lobular dot, but they're not cysts, because to be a cyst, you really have to have a thin wall. And these areas of central lobular emphysema classically will not have thin walls. They'll just be areas of blackness, areas of hypodensity, essentially lung destruction. Here's a more advanced case of destructive emphysema in the upper aspect of lungs. And so obviously emphysema can get this bad. And in these cases, really it's not a diagnostic conundrum. You know exactly what you're dealing with. This is a case of really bad emphysema in the upper aspect of lungs. So some people have told me my general approach, that was an approach a few slides ago, that was an approach that I teach all my resident fellows. And they said, that seems a little bit like elementary. Isn't there something more sophisticated? It's a more sophisticated way you go about it. And so I said, yeah, there actually is, right? And actually it's pretty good, but this is not the approach that I use, but other people like this approach because it's sort of like this more structured framework. This was actually published by Escalon and Lynch so these are my former colleagues at National Jewish. And so they took LCH out of it, pulmonary Langerhans cell histiocytosis out of it, because again, it looks so different. So once you take LCH out, then you're left with lymphangiomyomatosis, LIP, and Birt-Hug-Dubé syndrome. And so what's a diagnostic approach when you're left with these three clinical situations? Well, you have to ask yourself, is it diffuse? If it's diffuse, it's probably lymphangiomyomatosis. But remember, LAM really is a disease of women. So if it's a man, it's probably not LAM. You're probably dealing with something else. You'll probably want to go for a LIP or Birt-Hug-Dubé syndrome. That's probably what it is. But if it's diffuse and it's a woman, almost always LAM. If it's lower lung preponderant, then what? Now you're dealing with usually a LIP case or BHD case, let's just say that, BHD case. And so how do you figure out LIP versus BHD? Well, so Birt-Hug-Dubé, for some reason, it likes to give you these elliptical paramediastinal cysts. And I'll show you a couple examples in a little bit. It looks very funny. When you see it, it's so characteristic, you can just burn that into your brain, and it's really, really specific for that disease setting. And then also, it tends to give these little elliptical cysts as well, though that's not as specific. There's some overlap with these elliptical cysts and LIP. But for completeness sake, I'll show you some examples of that as well, and also explain the pathophysiology, why you get these sort of elliptical cysts with Birt-Hug-Dubé. And so if not, it's probably LIP. LIP is probably going to be more common than Birt-Hug-Dubé. Again, there's mixed data on this because it's hard to diagnose these patients with cystic lung disease. Cystic lung disease is probably very under-recognized, not just in the community, but also in academic centers as well. So it's hard to get accurate data. But LIP is probably more common than Birt-Hug-Dubé. So if it doesn't have this paramediastinal distribution, then you're probably dealing with a case of LIP. So this is another approach you can take as well. And this is an excellent paper by Escalon in 2019. The accuracy of this approach was anywhere from 60 to like 94%. I think that if you average all the numbers, it comes out to something like 80 something, like mid 80%. That's pretty darn good when it comes to diffuse cystic lung disease, and it's certainly better than the pulmonologist. All right, so that leads us to the specific diseases that cause cystic lung disease. We're going to start with pulmonary Langerhans cell histiocytosis just to get it out of the way. It looks so different from the other cystic lung diseases. This is classic. LCH is almost always. I've seen one case out of maybe 150 cases that I've seen through my clinical work and my research studies where it wasn't upper lung preponderant, where there was equal involvement of the lower lung zones as well. But very common to get these weird, bizarre-shaped cysts which have coalesced into each other, these kind of odd-shaped cysts with kind of angulations. Very commonly, you'll see these small central lobular nodules as well. Some of these have cavitated out, giving me this Cheerios-like appearance. Here, so some of these cysts, when they start to coalesce, they'll have areas that are thin and areas that are thick, as you can see. So very ugly looking. They start to run into each other. You could tell that this is not your typical course of emphysema, right? Emphysema has essentially lung destruction. This has something more. These are interesting cysts. More example here of some round cysts. So these round cysts, remember these cystic lung disease in Langerhans cell histiocytosis, they emanate from small nodules which eventually cavitate out and then start to grow larger and larger and then run into each other. That's why very often you'll see these smaller cysts and then concomitant adjacent nodules. Here's some examples of the nodules there. More nodules. The nodules here, when they cavitate early on, they have this Cheerio-like configuration. Some people will call that the Cheerio sign. I alluded to the upper lung preponderance as well. And so this is, again, just demonstrating that upper lung preponderance. Costarian angles are classically spared. Another example here of Langerhans cell histiocytosis. Again, these very interesting, bizarre-shaped cysts. They don't look pretty, and then these areas of nodularity, some of them which have cavitated out, Costarian angles spared. More example, this has fewer nodules, fewer of these Cheerio-like lesions, but more of the cysts, and the cysts don't look round or oval, or most of them, let me take a step back. We have a lot of cysts here which have run into each other and have sort of coalesced into these odd-shaped patterns, kind of look like blobs, and then other smaller cysts which are more oval and round in configuration. And again, upper lung preponderant, pulmonary Langerhans cell histiocytosis. I'd be remiss if I didn't mention this. In some patients with Langerhans cell histiocytosis, they have a little bit of fibrosis as well. And so when you see patients who have what looks like emphysema plus, you know what I'm talking about? I'm sure you've seen these cases where it's like, yeah, it looks like emphysema, but there's like a lot of little lines, a lot of little interstitial opacity superimposed on it in the upper aspect of the lungs. And if you look carefully, you'll see a lot of these scattered central lobular nodules, maybe some Cheerios-like lesions as well. Almost so surely this patient has Langerhans cell histiocytosis, which is burnt out. That is not a term that you'll find in the Fleischner guidelines, but this is a term that I think most chest radiologists will use, this sort of burnt out pattern of Langerhans cell histiocytosis. So this patient's inflammatory phase of LCH has evolved into not just a cystic lung disease, but also some degree of fibrosis. And so not an uncommon pattern here. If you keep your eyes open, I'm sure you will see one of these cases in the next couple of years. This is not that rare for this to happen, this burnt out pattern of LCH. I'm sure I missed a bunch of these when I was a resident fellow because I just wasn't aware of this pattern. But after I learned about this pattern, I said, oh, okay, I saw this before where I was confused. I didn't really know what's going on. But the emphysema plus the interstitial stuff, keep it in your working memory. LCH. Cost for angle is spared. Okay, so we got LCH out of the way. So different from the other cystic lung disease. It's kind of a home run. We used to biopsy those patients. We used to think that we had to biopsy them. But I'd say like most chest radiologists now, it's really an imaging diagnosis. We rarely diagnose these patients with pulmonary Langerhans cell histiocytosis because the imaging characteristics are so specific for this diagnosis. Okay, let's talk about LAM here, lymphangiomatosis. Again, usually a diagnosis of women, childbearing age women. But let's talk about the morphology that we're going to see. These cysts, in contradistinction to LCH, are pretty cysts. These are beautiful cysts. If you had no idea what cystic lung disease was, and someone told you cystic lung disease, this is probably what you would imagine what cystic lung disease looks like. Just pretty oval, round cysts, very thin, very homogeneous, all throughout the lungs, evenly spaced. Intervening lung is essentially normal. Diffuse distribution in all planes, both up and down, superior, inferior, as well as the axial plane of the CT scan, will obviously involve the costophrenic angles as well because it's a diffuse distribution. Not uncommon to get concomitant renal angiomyolipomas. We know that patients with LAM, they can get idiopathic LAM, but they also get LAM associated with tuberous sclerosis as well. Excuse me. But you can get these angiomyopomas either in idiopathic disease or in patients with tuberous sclerosis. Sometimes you get these hepatic angiomyolipomas as well. Another patient with lymphangiomatosis. These are MINIPs, bilateral MINIPs to bring out the cystic lung disease. Again, diffuse cyst here. This has a little bit of a basilar predominance, but I'm sure this is LAM. This has been proven. This patient has LAM diagnosis, and this patient popped a little pneumothorax on the right, which again is brought out by the MINIP. And just more of the same. These all kind of look like the same patient, maybe at different levels of severity. These are pretty cysts, intervening lung normal, diffuse distribution. Another patient here, even on the chest radiograph here, I think you can see the increased interstitial markings throughout the lung parenchyma. Patient has a moderate right-sided pleural effusion. This turned out to be a chylous pleural effusion, which these patients will tend to develop. Patients with LAM are associated with chylous pleural effusions. And again, we see the diffuse cysts all throughout the lungs. Very pretty cysts, diffuse distribution, and just more of the same. Here's another patient. And so you're probably wondering, well, you showed these beautiful examples of cystic lung disease in LAM. Why are you showing now this not so great case? Is to remind me to tell you about the tuberous sclerosis component. So remember, a patient with tuberous sclerosis, they're going to have other concomitant findings. On chest CT, this is what I look for. If I know the patient's tuberous sclerosis, they often will develop these lipomas within the heart. So I look on the CT scan, whether it's contrast enhanced or non-contrast enhanced. And obviously, I'm looking at the upper abdomen for fatty lesions within the liver as well as the kidney. So these patients had bilateral renal angiomyolipomas as well as angiomyolipomas within the liver. Okay, so we talked about LAM now. We can talk about lymphocytic interstitial pneumonia now, or lymphocytic interstitial pneumonitis. I'll just call it LIP. And so LIP is interesting. So it can have different morphologies depending on when you catch it, when you see it. And so for me, when I see it in my clinic, usually it's a pure cystic lung disease, but there's also an inflammatory phase. So if you catch a patient during their inflammatory phase, you're looking for ground glass opacity, usually bilateral. Very nonspecific though, just ground glass opacity, sometimes with some superimposed reticulation. But for me, again, I'm looking for cysts. When I see it's more in the chronic phase, a lot of the inflammation has sort of burnt out, and we're seeing this diffuse cystic lung disease, which tends to be basilar and tends to be parabronchovascular or subpleural in its distribution. Parabronchovascular cysts, as you see here, you're going to see this pericystic dot, which is the adjacent vessel. But again, we have subpleural areas as well of cystic lung disease in the patient with LIP. I talked here's more ground glass opacity here. More ground glass opacity here, but more in the central lobar configuration. Unfortunately, the ground glass opacity, as well as the other aspects of inflammation that we see, patients with LIP are very, very nonspecific. The most specific finding we see actually is the cystic lung disease. And thankfully, again, for me, because I see most of these patients in that disease setting, it's quite helpful. Reticulation can be seen from time to time. It's probably a little bit of scarring or fibrosis, but it's not a common pattern that I tend to see, again, in my clinical practice. Here's another patient with Sjogren's syndrome and LIP. So why do I mention the Sjogren's syndrome? Remember my first talk, LIP is strongly associated with Sjogren's syndrome. The other disease setting that we think about LIP is in setting of immunodeficiency, specifically HIV and AIDS. But again, now that HIV and AIDS is less of an issue, I think most of the patients that you're going to see with LIP are going to have underlying Sjogren's syndrome. Beautiful example here, parabronchovascular and subpleural cysts. Again, basilar predominant process. That's what we expect to see in patients with LIP. Another example, this is the same example that I showed in my first talk. Again, basilar predominant, parabronchovascular, subpleural in distribution. This patient has some sort of, some associated residual inflammatory changes, these nodules within the lungs bilaterally, as well as some patchy ground glass. And again, the pericystic dot sign that we see in LIP. And just more of the same here. These all kind of look the same, don't they? But the basilar predominance is what is the giveaway. And so now let's talk about Birt-Hogdebay. And so the reason why we put Birt-Hogdebay and LIP right next to each other is because they look very, very similar. So both are basilar predominant. Both can give you these parabronchovascular and subpleural cysts. So how do you differentiate the two? That's probably the big takeaway from this latter half of the talk, because we've already established that LCH is easy, right? It's upper lung, it looks so different. We established LAM is diffuse, right? Young childbearing age women, right? It's the beautiful, it's the prototype of diffuse cystic lung disease. That's pretty easy. So it's these last two, LIP and Birt-Hogdebay. How do you differentiate the two? We'll go into it in more detail right now. So Birt-Hogdebay, we're looking for these paramediastinal cysts. Sometimes it's very subtle, but you got to look for it, right? So you see what you know. So in your mind, if you see someone with basilar predominant cysts, the first area you should look for is that paramediastinal area. Are there an inordinate number of cysts clustering in that paramediastinal region? If the answer is yes, it's probably Birt-Hogdebay syndrome. These cysts are thin-walled, they're uniform, they look exactly like, very similar to LIP. They do tend to be a little bit more multiseptated, as you show here, and also the air cuff sign has also been associated with Birt-Hogdebay. So what's the air cuff sign? It's when a vessel, usually within the lower lobe, but it can be in the right middle of the lingula, so a basilar predominant process, a vessel goes through the center of one of these cysts. So this vessel has a cuff of air around it. That being said, I've seen LIP do this as well, right? So the specificity is okay. I do think it's more common in Birt-Hogdebay, but you can see in LIP as well. The paramediastinal cysting, though, that's a very specific for Birt-Hogdebay syndrome. So about more example, of the same process here, this air cuff sign, this basilar predominant process. Again, that pattern, unfortunately, is non-specific. But here's a very specific pattern. So this patient with diffuse cystic lung disease, basilar predominant, as we can see on the MINIP, but look at these cysts clustering along the paramediastinal regions bilaterally, left greater than right. So if you see something like this, I mean, Birt-Hogdebay, 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 and if you're wrong, I think you'd be very wrong very rarely that you'd be wrong with this sort of disease phenotype. Another example of Birt-Hogdebay syndrome, see these paramediastinal cysts. Some areas are lenticular, these lenticular cysts as well, very typical of Birt-Hogdebay syndrome. Another example here of more mild cystic lung disease. I think this brings out some of the lenticular shape in a little bit better detail without some of the other noise. So Birt-Hogdebay, they tend to give you more of these lenticular cysts, but again, I've seen these in LIP, so it's not you can't hang your hat on the lenticular cyst phenotype, unfortunately. Another example of patient with Birt-Hogdebay, and so these are sort of non-specific. This could be LIP, this could be Birt-Hogdebay. So and here's the MINIP that kind of brings it out, right? So it's clearly basilar predominant. So why am I showing you this not so great example of diffuse cystic lung disease? I mean, are there even 7 cysts? I guess there are, right? 1, 2, 3, 4, 5, 6. Yeah, okay, fine. There's at least 7 cysts. So clearly we can still invoke the diffuse cystic lung disease here. It's because, remember, Birt-Hogg-Dubé, you also get renal tumors. So if you're thinking about Birt-Hogg-Dubé, or even if you're not thinking about Birt-Hogg-Dubé, you should always look at the upper abdomen as well and look at the kidneys. So you look at the kidneys for angiomyolipomas, and then also look for these solid tumors. So these are bilateral renal cell carcinomas. These patients with Birt-Hogg-Dubé, they can also develop oncocytomas as well, but usually they're going to be renal cell carcinomas, right? So we assume that they're renal cell carcinomas until proven otherwise. So this is a reason to look at the upper abdomen. I'm sure we all look at the upper abdomen as well on a regular chest CTs, but this is an extra pulmonary manifestation of Birt-Hogg-Dubé syndrome. Another thing that can help us differentiate Birt-Hogg-Dubé from other disease settings, this is actually a really nice paper published just a few years ago now that compared the cyst size on expiration and inspiration. So if you're doing inspiratory expiratory views, probably to do it right, you probably need quantitative imaging and you have to sort of add up all the volumes on expiration and inspiration. I'm not saying you have to do that, but this is just for you guys to know, have in your back pocket, and probably as AI develops, AI is going to start using this sort of information as well. But we know that patients with Birt-Hogg-Dubé, those cysts tend not to collapse as much as other cystic lung diseases. So that they have less of a reliable connection to the airway. And so why is that? It's because in Birt-Hogg-Dubé syndrome, the cysts tend to be perilobular, as you see here. So on the margins of the secondary pulmonary lobule. And so they don't reliably connect up with the central airway. Other cystic lung diseases, usually they're actually connecting up with the central airway because there's more central-lobular in their distribution. And so on inspiration, expiration, these cysts that are connecting with the central airways, obviously they can collapse more because the air can go somewhere. These perilobular cysts that we see in Birt-Hogg-Dubé, their air can't go anywhere, so they're not as compressible. This probably also explains why they're more lenticular, because this perilobular region allows it to be more lenticular in its appearance. Also, it probably explains why we get at least the subpleural distribution of these diseases in patients with Birt-Hogg-Dubé, not the paramediastinal distribution. No one has been able to explain to me why these patients with Birt-Hogg-Dubé get that paramediastinal preponderance. Okay, so this is my summary slide here. And so if you have someone with cystic lung disease, these are the 4 things you really want to think about. Remember, LCH, easy. Really, it looks so different. Bizarre shaped cysts, weird cysts, thick walls, thin walls, concomitant nodules, very common, Cheerios-like lesions, very, very different. We'll spare the cosophrenic angles. Very, very different. So set that one aside. So if now you have these pretty cysts, you have to decide, is it LAM, LIP, and Birt-Hogg-Dubé? Again, LAM, I think it's relatively easy. Diffuse distribution in the zonal plane as well as in the axial plane of the CT scan. Remember, demographics, it more or less has to be a woman. If it's a man, it can be LAM, usually in the setting of tuberous sclerosis, but even that's a case report. So it's probably not, right? It's like 99% it's going to be a woman. And so remember, it could be idiopathic disease or it could be related to tuberous sclerosis. If it's tuberous sclerosis, look for other manifestations of tuberous sclerosis throughout the imaging that you have, not just within the lung parenchyma. If you're pretty sure it's not LAM because the cysts are actually basal predominant, now we're dealing with that dichotomous differential diagnosis of LIP versus Birt-Hogg-Dubé. So how do you differentiate the two? Remember, Birt-Hogg-Dubé also will tend to give you these renal tumors. It can give you skin lesions as well, but we're not going to see that in imaging. But look at the upper abdomen. If they have clear renal cell tumors there, renal cell carcinomas, enhancing solid mass within the kidneys, come on, it's going to be Birt-Hogg-Dubé, right? It's how unlucky could you be to get LIP with Sjogren's disease and also get renal cell carcinoma on the same scan? It's going to be Birt-Hogg-Dubé. LIP, in terms of the clinical history, also very helpful. Remember, LIP will usually occur in patients with Sjogren's syndrome or sometimes with immunodeficiency, specifically HIV/AIDS. That can be quite helpful. But if you have none of that, let's say so you have no history, let's say the kidneys are clean, how do you differentiate the two? Really, what's most helpful are those paramediastinal cysts. So have a hawk eye, look at those paramediastinal regions very carefully. If you have paramediastinal cysts, think about Birt-Hogg-Dubé. If you don't have a conglomerate of paramediastinal cysts, think about LIP because it's going to be more common based on data as compared to Birt-Hogg-Dubé. Thank you very much for your attention.